Presentation. It is my great pleasure to introduce the next speaker, Professor Krish Sridhar. I hope you are there. To invite Professor Sridhar. He's going to talk about microvascular decompression, surgical nuances and lessons learned. So Sridhar, to you.
Thank you very much, my good friend Azmi. And thank you, Professor Rohadi, for this kind invitation. Of course, Professor Kato and all the organizers. And let me congratulate you on this wonderful meeting. You have taken it up one notch higher from the meeting we had last year. I'll just share my screen. So before we start, I would like to pay my respects to Professor Tetsuo Kano. This was the photograph in 1993. Professor Kato referred to this, but I was one of the recipients, and that was me here in 1993. Many of the current stalwarts of Asian neurosurgery were the benefactors of benefited from this meeting, which was the starting point of the ACNS. And really, I think we all owe a lot to Professor Kano for this great initiative, for the great education which has been started in Asia and nobody's been able to replicate this sort of an initiative anywhere else in the world. So I think all our respects to him, and may his soul rest in peace. This is one of the last photographs I had with Professor Kano. Always very friendly, easy to approach, easy to talk to, and he was a wonderful gentleman. And we all will remember him always. Professor Kato has taken on the mantle of the ACNS and really taken it to the next heights. This was in Jakarta when we came for ECA's meeting for the ACNN, and this was I mean, what a journey that has been. And also, so let me congratulate Professor Kato for, despite the pandemic, keeping education going. And the ACNS has really been a leader in that with all the webinars, with the young neurosurgeons activities. So congratulations, Professor Kato, for being who you are, ever active, evergreen. So thank you so much. Going on, last year, Azmi, we spoke about this meeting, and it was a tremendous 3 days, and we had the ACNN alongside. So there were 3 halls where we had all these meetings, and almost everybody from everywhere in the world was part of this. And I hope that we shall continue to have such meetings, because there is no restriction of travel. There is no problem of getting a visa or expenses. I remember once we had a meeting of the ACNN, and the nursing had this concern about their expenses for traveling to different parts of the world for the meetings. But when we have these virtual meetings, it is so nice that we are able to meet people from all over the world, almost from our own homes. And this is a wonderful initiative, and I'm so happy that I could be part of this. And we had a wonderful meeting last year, and we are having a wonderful meeting right now as well. So thank you, Professor Kato, and the rest of the ACNS board for this opportunity. Coming to microvascular decompression, we cannot speak about microvascular decompression without mentioning Dandy. And in this paper in 1934, he mentions that not infrequently the artery leaves its mark on the nerve, At times, the nerve is attached to the artery, and in 66, that is 30.7%, the artery in some point affected the nerve. And this was in 1930s. But after that, it was only Peter Geneta, who's here, who took microvascular decompression and the neurovascular conflict concept to the next level, and really took it to the world and took the spotlight to that cause of the different causes of cranial nerve dysfunction in the posterior fossa. This is in 2005 in St. Petersburg. And these are some beautiful articles written by Peter Geneta, and there are many more written by him and his team at Pittsburgh, which highlight the cause of trigeminal neuralgia and other neuralgic syndromes of the posterior fossa. Now, we all know the anatomy. So there are 3 neurovascular bundles in the posterior fossa, each with their own neurovascular conflict syndromes. And these have all been described in literature, the commonest being trigeminal neuralgia. This is again from Peter Geneta's article, but this statement is something which I think is a wonderful statement. The problem is not whether there is a blood vessel present, but whether the surgeon is astute enough to find all the significant blood vessels. So when there are people who say, oh, the MRI does not show a vessel, there are sometimes we find that even though the MRI does not show a vessel, we can find a vessel if we are astute enough and if we look properly, so that we can find the cause of the trigeminal neuralgia at surgery. Of course, currently there are multiple options for trigeminal neuralgia and other cranial neuropathies. The first being medication, and all patients should have a trial of medication before you advise any intervention. Non-ablative procedures is only one, which is microvascular decompression surgery. There are many ablative procedures, which include glycerol injection, balloon compression, RF lesioning, radiosurgery. But I think the most important aspect of treatment in my mind is that when we treat some disease or a non-cancerous, which is something which has normal anatomy, we should try to preserve things and not be destructive. So the real advantage of microvascular decompression surgery is that it is non-destructive. It's an anatomical and physiological surgery with full function preservation. And I think that is what is very important. And this is a surgery which is a very beautiful, precise surgery, which only requires a proper arachnoidal dissection. This is the classical picture of trigeminal neuralgia and the causative etiology of trigeminal neuralgia, and the diagram representing where the compression will be most of the time, and where the pain would be with relative to the compression. If you look at the techniques of microvascular decompression, if this were the nerve and this is the artery, there are 2 basic techniques. One, the interposition technique, where you just place material between the artery and the nerve. And the other is the transposition technique, where you make sure that the vessel is moved away completely from the nerve. And the technique of placing the material is completely different in the transposition technique as compared to the interposition technique. And I think this is very, very important. And in my mind, doing the transposition technique is a much, much better, gives you much, much better results. The chance of recurrence is much lower than the interposition technique. Of course, there are times and the vessels involved do not allow you to do a transposition technique, in which case you have no option but to do the interposition technique. and we shall be looking at all these issues. A CT-MR is mandatory to rule out lesions which cause tumors and cysts. This is very, very important. One should not venture an intervention without doing a proper MRI. We used to do a CT initially, but now with good MRIs, I think that is very, very essential. It is also important to do MRAs, and also when you are looking at radiology, it's very important to do sequences like the TOF and the cyst sequences, which will show you actually how the vessel is. More importantly, you must look for doliectatic vessels, which will or can give you a problem at surgery. And for you to be prepared, this study of radiology before you operate is very, very important. One must also remember that demyelination is a common cause of trigeminal neuralgia. And this demyelination plaque is often seen at the dress zone of the trigeminal nerve. The distinguishing factor of between demyelination as a cause and a neurovascular conflict as a cause is that in demyelination, very often the symptoms can completely disappear without any medication for a long period of time, while in a neurovascular conflict caused trigeminal neuralgia, it does not disappear so often. Intraoperative monitoring is good to use, but for trigeminal neuralgia, I am not very sure that we need to use this, but definitely for other neuralgias and other neurovascular conflict syndromes, I do use intraoperative monitoring, and this is very, very good if you have it. I do the surgery in a supine position with the head turned like this. I prefer not to use a lumbar drain. I like the subarachnoid space wet. I think the subarachnoid cisterns should have CSF, and because a dry cistern is never very nice, and therefore I do not use a lumbar drain. We used to use this safety burr hole for a long time as a fallback on how we used to do post-fossal tumors and other procedures. But now we have stopped using the safety burr hole. This is the incision that I use, a small incision behind the ear, and a coin-sized craniotomy or craniectomy based on the vessel, on the nerve that needs to be decompressed. Now, this diagram represents the posterior fossa, and what you need to expose is not the entire posterior fossa cistern, nor do you need to expose the entire cerebellum. A small craniotomy is more than enough, but that has to be tailored to whichever nerve has to be looked at. For example, the trigeminal nerve, you need to have the transverse and lateral sinuses exposed so that you can look at the entire trigeminal nerve from medial, the DRES and the brainstem, right up to the time where it exits the posterior fossa. For the lower cranial nerves, for glossopharyngeal neuralgia, it is good to have not only the lower cranial nerves exposed, but also a little bit of the vertebral artery as it enters the posterior fossa, because then that will give you access to the pica and the vertebral artery as they enter the posterior fossa. For the for hemifacial spasms and the cochlear vestibular nerve complex, you need to have a little bit of the lower cranial nerves also exposed, because your direction of retraction of the cerebellar surface should be such that it is not directly in line with the 7th and 8th nerves, but a little more from inferior, so that you can do not place traction on the 7th, 8th nerve complex. Small technical points: a very small craniotomy tailored to the nerve, as I said. You must open the arachnoid to release CSF and relax the brain. That is very, very important. Do not try to be in a hurry or a rush. to get to the nerve. Open only the arachnoid sleeve of the concerned nerve. And I think if you have read the chapter on the subarachnoid cisterns by Professor Yasargil in his micro-neurosurgery books, you will understand what I'm saying, that each of these neurovascular bundles has their own cistern, and you can see that at surgery. And it is best not to open the other cisterns, because the CSF and the arachnoid sleeves serve as protection in case there is some movement of your suction or instrument that touches the other nerve. And very, very important is fine and delicate micro dissection. And that is the key to good microvascular decompression. This is the size of the craniotomy that we do. It is about 1 inch, 2.5 centimeters, with the sinus well exposed so that you can really get a good exposure right up to where you want to go. And for a trigeminal neuralgia, please remember that you should be seeing this as soon as you open the dura. The junction between the posterior petrous surface and the tentorium, that is very, very important. If you are not seeing this, that means you are not in the right space. The next step generally in a microvascular decompression is when you retract the cerebellar surface from superior down. You will see the 5th nerve, you will see the superior petrosal vein, and you'll see the 7th, 8th nerves at the lower end of your craniotomy, and all in their own arachnoid sleeve. So you should not open the other arachnoid sleeves. You should just open where you want to go. And this is what you would see. You will see the trigeminal nerve in the depth. Now, I have seen, and unfortunately, I get to see some of these trigeminal neuralgias, which have been operated at other centers by sometimes younger neurosurgeons, who mistake the 7th, 8th complex for the trigeminal nerve. And it is so easy to see because it is the most posterior plane. The 5th nerve lies much more anterior. And that is something people have to remember, that the 5th nerve lies much more anterior to the 7th, 8th nerve complex. The second indicator is you must see the superior petrosal vein in your field for you to identify the 5th nerve. So please remember that. And then, of course, with meticulous dissection, the artery is moved away. Now, I use autologous muzzle bits. We have used Teflon, but I have found it not very user-friendly, and somehow I've never got around to being happy with it. So I've used in my 400 plus cases, used autologous muscle, and I've been quite happy with this. So this is how basically the microvascular decompression happens. So this is a video showing the microvascular decompression. And like I said, you must see the tentorium and the posterior petrosal surface. Magnification is very important. You let out CSF, let the cerebellum fall. Let the cerebellum fall. And here you will see this is the 7th, 8th nerve, and this is the trigeminal nerve. So do not mistake one for the other. Keep this arachnoid intact of the 7th nerve so that you are sure that you will not injure the 7th nerve. Very often the injury to the nerves happens because all the arachnoid is opened and invariably some traction somewhere and the nerve gets injured. Now, technical difficulties arise because of the size and position sometimes of the superior petrosal vein, anatomy of the posterior petrous surface, and of course, anatomy of the compressing vessels. Now, in this, you will see what happens. We have a large sinus, which is not allowing us to open the dura right up to the corner. And sometimes when we make these small cuts, we open up the lateral end of the sinus. And important thing is that one needs to control that. This is a very clean surgery, and therefore one should not have blood going into the cisterns. So what I now do is use these small Liga clips, which are micro Liga clips, and occlude the lateral end of the sinus, use topical hemostats alongside that, and then you're good to go. But remember that these have to be placed in such a way that it does not come in the way of your instruments. Otherwise, just when you are dissecting the arachnoid of the cistern, you'll have venous blood pouring in, and that will make your surgery very, very messy. The surgery needs to be very, very precise and needs to be done through small corridors. It is not good to have very, very pulling or pushing techniques. This is not good, and therefore you have to be very, very gentle. Sometimes when you open up the dura and enter, you see the superior petrosal vein right in the center of where you want to go, and there is a thick arachnoid. So the arachnoid has to be opened. The superior petrosal vein has to be skeletonized. And sometimes even when you do this, you see that the trigeminal nerve is completely covered and you're not able to see anything. So you would have to do a lot of venous arachnoidal dissection. And this is where I think young neurosurgeons need to go to the lab. They need to practice and in the lab doing dissection. And this is very, very important. Microsurgical dissection is the key to a good surgery, whether it is aneurysm surgery, whether it is acoustic surgery, whatever it is. I think arachnoidal dissection is the key. And one needs to be able to do fine, delicate arachnoidal dissection, sharp dissection, so that one can release the superior petrosal vein, create space as one goes along so that one can get between. So you see now you're seeing almost the dress of the fifth nerve between the branches of the superior petrosal vein. And that is very, very important to do. And one should be aware that sometimes this is a position where you will be. And now you have to work between the two branches of the superior petrosal vein to do this. Without doing this dissection, it would be impossible to reach the pathology. Now, occasionally what happens, this is the same continuation of the same video, and here you have got the dissection of the superior petrosal vein. But what I want to show in this video is sometimes what you see first may not be the actual pathology. And you would have to be, remember Janeta's statement, the surgeon has to be adept at identifying all the vessels involved, not only one vessel. So it can be more than one vessel. So what you're seeing here is one vessel placed dorsally, but there is one more vessel placed anteriorly there. There you can see the loop, which is going anterior to the nerve and causing an indentation. And that's actually the pathology. And one has to operate under high magnification. Occasionally, when one is unsure, the endoscope must be on standby. You use the endoscope and see what you're doing, and you must need to release all the nerves. So my technique is to displace the nerves completely and do the transposition technique. And this is very, very important. You must take your time, understand what is happening to the anatomy of the vessels, and then only place these small bits of autologous muscle so that the vessel is moved away completely. Remember, when you move these vessels away, there must be no kink in the vessel. Otherwise, you will create an ischemic area post-surgery. So that is also something which must be looked into, that there must be no kink, and this is towards the end of surgery. And this is the second vessel which you see first, and that too sometimes would have to be taken care of. If you're not sure, it is better to dissect that and then put a graft between that and the nerve. And that is what is being done here. So this is all has to be done very gently and delicately. Sometimes as soon as you open, you see large vessels like this. And this vessel seems to be the one which is indenting the nerve. And you see that there are a lot of arachnoidal adhesions. Now remember, all the artery has to be completely freed. And then you can see the severe indentation caused. You can see that the nerve almost has a concave surface. But then this is not the artery alone. And then when you dissect further, you then see there is one more vessel which is going inside and really invaginating the nerve. Remember, these small perforator vessels, there should be no traction. And you must be very, very gentle. Like I said, no pulling, pushing. It must be very gentle movement under high magnification and slowly ease the artery out. And that is something which must be done with a lot of delicacy, because these are all normal vessels. There is nothing abnormal here. So you must pay respect to each of these structures. So you sometimes would have to go between the perforators and try to release the vessel. Now we have released the nerve completely now, and then you now place the autologous muscle bits. The key to a successful microvascular decompression is to see the anatomy completely. And without doing that, you will not be able to get a good result. So once we have ensured that the vessel loop is never going to come back, you then have to ensure that what is even inferior. So there is a small vessel inferiorly here. So you have to pay attention to that as well and ensure that no vessel is in direct contact. So now the arachnoidal dissection has been done of that, and then the vessel is away, and then you place the graft in the right position. Sometimes you have large vessels, doliectatic vessels, which have to be dissected. And this is sometimes the most difficult part of a microvascular decompression, because these vessels will not, this is the superior petrosal vein, which has been dissected. That is the superior cerebellar artery loop. But the main indenting vessel is this large vessel that you see that I'm just now pushing away. And once it is pushed away, you then have to ensure that it stays away. And that is very, very difficult, because the vessel is a large vessel. It is a heavy vessel. So it is difficult. And therefore, there have been many techniques described. You have slings which are described. Look at the size of the vessel compared to the nerve. Therefore, you would have to ensure that, you really make sure. And this is, you would have to go on both sides of the superior petrosal vein, ensuring there is no traction on the vein, but make sure that completely the nerve is free. At the end of the day, that is what would have to be done. Now, sometimes in this situation, all that you can do is an interposition graft. And this is something which would have to be done. And this is what was done for this case. This artery, which is inferior, is also taken care of, and that is at the end of surgery. One important point which many of us forget to look at is the suprameatal petrous ridge. Now, this is the suprameatal petrous ridge, which you would see on CT scans, which is just above the porus trigeminalis, where the trigeminal nerve exits the posterior fossa. If it is more than 3 millimeters, it is significant and it can cause a problem during surgery. Now, this was a patient who came to us with severe trigeminal neuralgia. And look at this. This is the suprameatal petrous ridge, which is there, which is hindering the view of the rest of the trigeminal nerve. You can see that this is the offending vessel, but you can't really see the rest of the loop. So in order to get that, now this is you can see that this is the ridge and this is the nerve. So this is actually abutting the nerve. So you would have to get there. So you would have to drill this suprameatal ridge. Now, I normally put, even in acoustics or other things, put a small piece of gel foam inside so that the bone dust does not settle onto the structures deeper. You need to use a small diamond head. Be very careful because there is no space for maneuvering. The superior petrosal vein is above, the 7th, 8th nerve complex is below, and therefore you gradually drill the suprameatal ridge till you are actually able to see what you are doing, and you can see the entire loop. So once you drill more and more, there is no problem drilling here, except the fact that you have to be very, very precise. So microvascular decompression surgery is not a simple surgery which you can take lightly. It is something which requires a lot of practice and experience and knowing what to do when the situation demands what you have to do. And now that we have drilled that meatal ridge, we are now able to do the surgery. Sometimes it's a vein which is causing the compression, and here you would have to dissect that vein completely and then have to so here the vein has been completely dissected and the muscle placed between the vein and the nerve. Glossopharyngeal neuralgia presents its own problems. This is the view that you would get when you start the surgery. So you would have to see the choroid plexus, and then you would have to look for the vessel, which is sometimes can be anterior. In this particular case, it was a large vertebral artery which was taking an acute turn, and that's the vertebral artery which is compressing the nerve, and that would have to be dissected away. And that has to be completely dissected away very carefully.
You have 1 minute to summarize.
Okay. So this is the this is the vertebral artery, and this is sometimes can be difficult. So tinnitus and disabling positional vertigo is something which people do not look at because the results are variable. Success is seen in up to 75 to 80% and needs a complete audiological evaluation, and intraoperative monitoring is very, very necessary. This is what you would see. I will just show you some of the cases that we have done. This is how it is done. And you have to be very, very careful. And as you would see in this particular patient, you can sometimes see a large vessel going between the facial and the cochleovestibular nerve, which requires very fine dissection. And you have to make sure that the job is done. Of course, facial nerve monitoring is needed, and you would have to do what is necessary. You would have loops going around. Orientation of the cochleofacial nerve complex is difficult. I will just keep moving on. Redo MVDs are very difficult because it is really a lot of tough dissection because everything is stuck. And therefore, the first time you do the surgery is the best time. So redo surgeries require a lot of time and a lot of very, very difficult dissection. So the complications of MVD are most often avoidable, and one must maintain strict microsurgical and anatomical principles. And very good micro-arachnoidal dissection techniques are vital for good results. Young neurosurgeons must practice, and that is the most important key to good microsurgery. So thank you very much. Thank you for your patient listening.
Thank you, Sridhar. Very wonderful presentation. Thank you for keeping on time. I think Prof. Sridhar has demonstrated his elegant technique. I only listened preservation. I never heard the word sacrifice. So it's all about anatomy, delicacy, respecting the vessels. You have to find all the offending, conflicting vessel, artery, vein. And he also demonstrated a very nice technique, including managing complication right from opening, and then when you can have a bleeding, for example, from the sinus. And he also demonstrated us from fresh case to a redo case, and as well as his technique of using the autologous muscles. I believe that there are many questions, but we cannot discuss live because plenary, we have to be on time. But you can write in the chat box, and subsequently, I hope the speaker will respond to the question.
1, 2, 3,